All right. Good evening, everyone, and welcome to tonight's webinar, Navigating Egg Donation as LGBTQ plus couple. My name is Irina MacArthur, and I'm Director of Patient Experience at Inception Fertility. And my role is to ensure that all our patients feel informed, supported, and empowered throughout their fertility journey. Tonight's session is for couples who are thinking about or already going through egg donation to start a family. We'll be talking about everything you need to know, from how it might feel emotionally, to choosing the donor, to understand the medical steps so you can make clear and confident choices. And we are absolutely honored to have this session led by Dr. Addison Bloom, a compassionate and highly respected reproductive endocrinologist from Mainline Fertility in Philadelphia. Dr. Broom brings a deep understanding of the unique challenges and opportunities for LGBTQ plus couples, what they can face, and she's committed in creating an inclusive and affirming fertility care. Please feel free to submit your questions in the Q&A box, and we will answer all the questions at the end of the session tonight. With that, I'm delighted to turn it over to Dr. Bloom to guide us through this conversation tonight.
All right. Thank you, Irina. I'm excited to be here. So not only we're going to talk about egg donation, but tonight I'm going to kind of bring you through all the initial decisions or things that we have to think about as we're considering this journey, all the way through bringing home that baby, and kind of touch on all the pieces of the puzzle along the way. So we'll talk about decisions and getting started, the initial intended parent evaluation. We'll talk about some decisions in donor egg selection. We'll go through some of the medical IVF process just so you have an understanding of what your donors are going through. We'll talk about some options for genetic testing. Then we'll talk a little bit about the gestational carrier, gestational surrogate matching process. I'm going to use those words interchangeably a lot. So gestational surrogate, gestational carrier used fairly interchangeable. You'll also see it used as GC a lot in this presentation. Right after that, we'll talk about the evaluation of the carrier, and then finally the embryo transfer and that early pregnancy transition to care. Next slide. So the first steps is really learning, and this is what we're doing today. So we're learning from every resource that's out there. This is a huge journey, and it takes a lot of people and a lot of components. And I really encourage you to watch webinars and go and use resources that are out there, like Gays with Kids and Men Having Babies and Resolve and family equality, really anything that's out there. Just learn as much as you can. The more that you understand about the process, the better you're going to be able to ask the right questions or know and what you don't know in the process. Not only have to understand the medical piece, really have to understand the psychological piece and legal aspects. There's lots of options along the way, and we're going to talk about a lot of those options tonight, but we need to learn about what those options are. And then finally, we need to understand how we're going to pay for these things, because this is not a cheap journey. And thankfully, a lot more insurances are covering pieces of this journey. So really understanding what your insurance covers, both you and your partner, and also understand what financial programs are out there and grants and other things that you may be able to use to help build your family. The next thing you want to start thinking about is conversations with your partner about your family building goals. So how many children do you want? What sort of timeline are we looking at to build this family? Do we want to have a sibling journey where we have children very close together or carriers at the same time? Or do we want to have children spaced out? Are both partners going to participate in using their sperm, or only one partner is going to use their sperm? Finally, when we get to egg donor options, lots and lots of options here. We're going to talk a little bit more detail here, but are we looking to use someone you know? Are we interested in making sure that we have the ability to know this donor in the future? Or do we want this donor to be anonymous? And the same thing with surrogacy options. Really, we're looking for, where does this surrogate live? Are your beliefs aligned? And we'll get a little bit more into that as we move through the slides. And then finally, when you kind of considered all these options and learned the basics, it's time to kind of select the big things here. And the first one is your IVF clinic. And this is where the magic happens in the lab. So this is where we're going to create the embryos with donor egg and your sperm. We're also going to do all the medical evaluation, care of the gestational carrier, and the coordination of care between you as the intended parents, the agency, and the gestational carrier. And then finally, and a lot of times people are doing this in tandem, choosing a surrogacy agency is the most common thing to do because it is a very complex process. And they are going to really put all the pieces of the puzzle together for you. They're going to include all the psychological pieces that are required. They're going to screen your carriers. They're going to get you in touch with the appropriate legal advocates for you. And they're going to also assist with the coordination of care with your IVF clinic and making sure your carrier has the appropriate care, they are at the correct places. Next slide. So when we think about choosing an IVF clinic, of course, as a gay couple, you want to make sure this place feels comfortable. So you want to go to a place where there's affirming providers and teams. You want to make sure that their experience working with gay couples. This is not something that they're doing for the first time, right? This is something that is more of their normal. I don't want my gay couples being treated any different than any other patient that walks into my clinic, right? They should feel like everybody else. And I think that's important. We also really want you to have a dedicated third-party reproductive team. So again, really complicated process with all the parties involved. And when we have a team that's dedicated to just working with intended parents and carriers and agencies, the experience is very cohesive. They talk to these agencies every day. They know their names and they know the people. And it makes for a very fluid process. Finally, you want to know about their egg bank options. Some clinics are going to have egg banks in-house. Some of them are not. Some clinics are going to have frozen eggs. Some clinics are going to have fresh eggs. Some clinics are going to have eggs that are from anonymous donors. Some clinics are going to have donors that you're going to be able to know that donor when the child turns 18. And some clinics or donor agencies are going to have open donors. And also the ability to work with outside egg banks if that's something you want. So these are things you want to ask in your process. Finally, of course, a good embryology lab. The clinic location, this matters a little to some people. So for an intended parent, a lot of these initial visits can be done via Zoom now or some sort of telehealth. You will need to be in the office probably 2 times, right? For your initial consultation, likely some blood work and a semen analysis or freeze. A lot of times we can even do this in 1 visit. Your gestational carrier is going to be there twice, one for an initial evaluation and once for their embryo transfer. But if the carrier is close to the clinic, they can come more for those monitoring visits. If you're close to our clinic, you can be more involved in your carrier's visits, like the day of transfer or their evaluation. So for some people, this is important, but there's not a lot of visits, so it's not that important. And finally, reputation, success rate. Read what other people think. What are other people's experiences? Are they being transparent with, what they have to offer you in terms of finances and outcomes? Now, next slide. Thank you. Okay, so when you get into the IVF clinic, this is really what your journey kind of looks like. So you'll have an initial patient consult, usually with your physician, and this will be either in person or online. And really, you're going to just talk. And what are you going to talk about are a lot of those decisions, a lot of those, what does your family look like to you? And, what have you thought about? What are your hopes and dreams? Then we're going to work on an evaluation of the attendant parents. We'll work on choosing an egg donor, going into the IVF lab and creating embryos. Then there's a big pause where we do the matching process, usually with an agency. Then we'll receive you back to our clinic and start working with the carrier, evaluating them, frozen embryo transfer, and hopefully sending you off very quickly pregnant. We'll get into these much more detail. Next slide. So initially, the intended parent screening is where most people are going to start. So part of that new patient visit, we're going to talk about your medical history, really looking for things that are going to affect sperm mostly. So any medications that can affect sperm, finasteride is a big one. Lots of the guys are worried about their hair these days. Looking for things that people do that can affect sperm, like smoking or marijuana use or excessive alcohol. Looking for comorbidities that we may need to optimize before we produce the sperm that's going to eventually create our children. Infectious disease testing, of course, and this will include FDA eligibility. So because this embryo is going to go into another person, we need to make sure that the egg and the sperm is cleared and safe for our carriers. So all the donor eggs will clear FDA screening, but all our sperm and intended parents will need to do this as well. And this is really as simple as doing some infectious disease testing that will go to an FDA lab and be certified and signed on the dotted line to keep everybody safe. And finally, a big one is genetic carrier screening. And I always sort of joke with my patients about going back to like fifth grade, sixth grade science and remembering the Punnett square. And this on the bottom here is a example of a cystic fibrosis gene. So for example, if you are a carrier for a gene, which means you carry one trait of the gene, and if the donor is a carrier for the same gene, then 25% of your children would actually have cystic fibrosis. So in the setting where we're choosing a donor, this can be easily avoided, right? So we will test the intended parents for over 500 genes. The donors are tested as well. And what we do is make sure that you don't match on any of those genes. And if we don't match on any of those genes, then the chance of having one of these autosomal recessive disorders is very rare. So this is really important. In a heterosexual couple or a situation of a known donor that does match, we can do additional testing on the embryos to screen out these affected embryos, but we don't want to add that additional cost and work if we don't have to. So when we're choosing a donor, we try not to match those genes. And then finally, semen analysis. Obviously, this is the most important part for the intended parents and the thing that they have the most control over. So this will be a production, and we'll look at the concentration and the motility and the morphology, which is the way the sperm looks. And honestly, most sperm is abnormal, but we just need some good ones. And usually, as long as there's some good ones, we do well. Next slide, please. So to me, this is a really important part of my first visit with guys. Is this is something that you have control over and you can do. So unlike women who are born with all their eggs, men make new sperm every 72 days. So anything that you do in the 3 months prior to the day that you're producing sperm for your future children is going to impact the quality of your sperm. So you really have the ability to make some difference in how good your sperm is that day. So things to start thinking about is, of course, maintaining a healthy weight, diet, exercising regularly, avoiding tobacco, excessive alcohol, marijuana, minimizing heat exposure. This is a big one. The saunas, steam rooms, hot tubs. That is a big one that people don't think of and tends to be a thing that I see my gay patients using a lot at the gym, and we have to kind of cut that out for the 3 months prior to this production. Of course, managing stress, sleep, avoiding tight-fitting underwear or chronic tucking for drag or other reasons. Bike riding. We love exercise, but everyday bike riding is not good for your sperm. So just not doing that for the 3 months before. And then also being open and discuss your medications and your supplements, because some of these medications and supplements can also impact your sperm, and stopping them for a short period of time can actually improve your counts as well. Next slide. Okay, so we're going to switch over. So that was the evaluation of the intended parent. We're going to switch over to the next most important step is choosing your donor. And this is a hard step because there's a lot of decisions to be made here. So the first thing we think about is the donor type. And the most common types of donor are an anonymous donor. This is a donor that you and your child will not be able to contact in the future. They will not release their identity. However, because of 23andMe and all these hereditary things online, these donors are extensively counseled that this is probably not anonymous and that there is a high chance that someone will find them one day. The next thing, which has become the more common way of donation right now, is called open ID. And this is where the donor agrees that when the child is 18 or older, if they desire to get the identity of their donor, that the egg bank will share that identity with the child or parent. And this is really just name and phone number, address, some sort of way of contacting, and we do ask the donors to try to keep that updated with us in some way. And then finally is a known donor. So this could be a friend, relative, and also could be a match donation. So now there are agencies that match donors with intended parents. So this is not someone you knew before, but you will know them. So you'll have at least some meaningful meeting and get to know them and establish some guidelines for a relationship moving forward. Other things to consider, of course, are things like race, physical features. Then you're going to go deeper into personality. Are they athletic? What's their education and interests like? Sometimes people try to have their donor represent the non-genetic partner. We see this a lot with sperm donation when we're looking at same-sex female couples, looking for characteristics of their partner in the donor. You'll have access to donor profiles, pictures, essays, reasons why they want to donate. But I also remind people that most of these donors are young for a reason. So they don't have long-term careers. Most of them are in school. So you have to read and understand, where you were when you were 23. We're not looking for someone who is 40 and established in a big, career. And then finally, you want to think about, what are you going to tell your children, right? Why did you pick this donor? What stood out about her, and how are you going to talk to your child about that? And make sure that is meaningful enough that you can relay that to your child, and that feels important to them. Next slide. Okay, next decision is fresh versus frozen eggs. And this kind of goes back and forth, but overall, in a good IVF lab, the success rates are similar. Okay, so really some of this is about your flexibility and family planning goals. So with fresh eggs, the egg donor is going through a fresh IVF cycle. They're being stimulated, which we'll talk about. And then the eggs are being fertilized the day of their egg retrieval. So they are never frozen. They're being fertilized the same day. So typically the way these work is you get more eggs. You may not get all of them. Usually clinics have programs up to a certain number of eggs. Typically, this is used when we're using 2 sperm sources or we're looking to have more than 1 child, because overall we intend to get, or we expect to get, more eggs. More eggs hopefully equals more embryos. Typically, this is also a higher cost. And it often takes more time because we have to synchronize an egg donor with their intended parent. So you may find a donor you like, and she might be going on vacation and not starting for another month or so, and we need to wait till she's ready to start. So there may not be as many options of donors who are coming through during their cycle. Frozen eggs, those are available. So they are in the bank waiting for you. They come in cohorts, typically somewhere between 6 and 8 eggs. Once you pick your frozen cohort, you set up a thaw with all the logistics around the clinic. It can't be like the next day, but it happens very quickly. We're not waiting on a coordination. We tend to use these with a single child goal, right? So maybe 6 eggs, they want 1 child, but this can be very easily taken into sibling journeys as well. You just will need to buy more than 1 cohort. So you may end up getting 2, 3, 4 cohorts of frozen eggs to have enough to create embryos for enough children in the future. Typically a lower cost, But when you add those cohorts together, it may end up being very similar. So depending on your family building goals, you're going to talk to your clinic and you're going to talk to your provider about what seems best for you at that time. Next slide, sorry. All right. So when we think about our egg donors are screened very, very thoroughly, and very few people who apply to be an egg donor actually become egg donors. So most people, most clinics or egg banks have a cutoff of around 21 to 32. There are some exceptions to the 32 plus for sibling journeys, but that's most of the age brackets. Of course, they have to be at baseline physically, mentally healthy, non-smoker, no drug use, no excessive alcohol use. We're going to go back to multiple generations of family history, looking for trends like heart problems or cancer or things that are happening in multiple generations. They will then be evaluated for the egg reserve, right? We do not want an egg donor coming through and giving us 5 eggs. We're hoping that these donors produce a lot of eggs at a time, so we have the ability to give our intended parents a good number of eggs to work with. They will have the same medical eligibility screening that you will have. So they will have blood work, they will have genetic testing, they will also have a psychological education and evaluation for their willingness or why their desire to do this, making sure they're ready to do this. They'll also have a very intense informed consent, disclosure terms in terms of whether this child be able to contact them, and then of course very strong legal contracts that includes waiving their parental rights. Just as note, if you use a known donor, the criteria is a little bit more flexible. So if you have a sister who's 35, we can use that donor. We just have to evaluate her, and we will be very honest with you about what her prognosis is, what her egg reserve is, how do we think she's going to do, and we make an informed decision together if we let your donor go through. They still have to do all the FDA and psychological legal guidelines, but the criteria for age and medical problems and other things are a little less stringent when it comes to someone you know. Oh, next slide. Okay, so now we're going to create some embryos here. So this is what happens in the IVF world. So your donor is going to go through what's called an IVF stimulation. And that entails about 10 to 12 days of her injecting medications in her belly by herself at home every day. It's usually a combination of 2 to 3 injections a day. And she'll be in our office having blood work and ultrasound about 4 or 5 times over that period. Every time she comes into the office, we're looking at her ovaries and we're looking at all these little follicles, and I call them little baby egg homes. And what we want them to do is grow into big baby egg homes. And once they're mature, based on their size, we hope that they contain a mature egg. So once we get them to a lot of them to a nice mature size, we will trigger ovulation, and 36 hours later, she'll have her egg retrieval. So for the egg retrieval, she does go under anesthesia, and the eggs are retrieved vaginally. So she'll have an ultrasound. If you can see in this little picture, you see the needle coming through the back wall of the vagina, and we put it into each one of these follicles and we suck the fluid out. So the eggs are microscopic, we can't see them, but we hand this fluid off to the embryologist, and they basically are searching for eggs under the microscope as we're doing these egg retrievals. So again, your donors are going through about 2 weeks of injectable medications, multiple monitoring visits, anesthesia, egg retrieval, and recovery. So it is a big ask, and we thank them, and we're very thankful for what they do for us and for our attendant parents. Next slide, please. So now comes your part. So once we have these eggs in the lab, if it's a fresh cycle, we can do what's called classic or standard IVF, where we let about 150,000 sperm swim around each egg, and it's like survival of the fittest. The best one wins, or the best one gets in. We typically do that if the sperm is good and if these eggs are fresh. If the eggs are frozen or we have lower sperm counts, we're typically doing what's called ICSI, or intracytoplasmic sperm injection. This is where the embryologist will choose one good-looking sperm and inject one sperm into each egg. The next day, we find out how many of these eggs fertilize. We typically see about 70 to 80% fertilization rate. And then the embryos are left untouched for about 5 days. On day 5, the embryologists take them out, they look at them under the microscope, and now we're looking for blastocysts. So blastocysts are the stage of the embryo that is good for transfer. So any embryo that makes it to the blastocyst stage, and I always say if it makes the cut, so it has to be good or fair quality, then has the ability to be biopsied for genetic testing or frozen. On day 6, anybody who didn't make the cut on day 5, they take them back out, do the same thing on day 7. After day 7, anybody that doesn't make the cut, those are discarded. And we typically see about 30 to 50% of fertilized eggs or day 3 embryos make it to the blastocyst stage, but it definitely varies based on egg quality and sperm quality. And often we'll see when we use 2 sperm sources with the same eggs, we may see very different blastocyst rates. And that really shows that the sperm has a big impact on embryo development. Next slide. So the option for PGTA, which is pre-implantation genetic testing, is that small little biopsy that's taken from the area of the embryo that will become the placenta. So 5 to 7 tiny little cells are biopsied, and the embryo is frozen for use later. Those cells are sent out to a genetic lab and they're analyzed just for this. So they're just counting the number of chromosomes. So if the number of chromosomes looks like this, where there's a normal number of chromosomes, 46 and an X and a Y, that is considered euploid or normal. If a chromosome panel comes back and there's an extra 21 or a lack of a chromosome 4, those are considered aneuploid. Most of these aneuploid embryos are not compatible with life. Some of them are conditions that we know about, like Down syndrome. Although donors are going to have a lower rate of aneuploid because they're young, most intended parents that are going to use gestational carriers are going to choose to do genetic testing. And really, it's because of they're using somebody else to carry their child. There's a lot of preparation that goes into it. They want to minimize the number of cycles, and they also want to minimize the risk of miscarriage. And finally, the hardest thing is the risk of a potential genetically abnormal child that a carrier is carrying, that then you and that carrier need to go through tough decisions regarding termination. Although that will be decided during your legal contracts before, it's still something no one should have to go through. Things that are limited by PGTA, it doesn't check for all genes or genetic conditions. So it's not going to tell you that you may have a risk for X or Parkinson's or something. It's also not going to tell you if you have a congenital anomaly in the child, meaning they have a heart defect or a limb is missing. It's just looking for the number of chromosomes. Next slide. So this is the hardest part of IVF is the attrition rate, and it just shows how inefficient our biology is. And, intended parents always ask, why do I need so many eggs? I only want one child, or I only want 2 children. And it's really because of this inverted triangle or the funnel effect. And really, every follicle that we see on ultrasound is not going to have an egg. And every egg is not going to fertilize. And not every fertilized egg is going to become a blast. Not every blastocyst is going to be normal. Not every normal embryo is going to result in a pregnancy. And unfortunately, not every clinical pregnancy is going to result in a baby. We're still going to have some miscarriage rate in that group. So this is the hard piece. So that's why we need more eggs to have a good number of embryos at the end, so you have some security as you move into your carrier journey. Next slide. So now we hope we have embryos created, and we always hope that we have at least 2 embryos, euploid embryos, before we start this matching process. And I always tell patients that because if we match with a carrier that may take up to 18 months, we do this entire evaluation and we don't get pregnant with that first transfer, it's really hard to then pause and we'll go backwards. It's really good to have that extra embryo to move directly into a second transfer. But when we're looking at carriers, they're going to have no genetic link to intended parents. So in most situations, most clinics will not allow the egg donor to be the carrier. Um, the typical matching process with an agency will take about a year to 18 months. And this is why most people are choosing an agency or talking to agencies at the same time they're starting to research and talk to IVF clinics. And things to consider. Now, I'm not an agency, so I don't know exactly, but I know what people look for. Things they're looking for are in a carrier are their location, right? So certain states don't allow gestational carriers, so the agencies are going to make sure that your carrier lives in a state where this is legal. They're also going to have preferences if their carrier lives close to them or it doesn't matter. Is the carrier willing to travel and how much are they willing to travel during that pregnancy? Also, are you comfortable with the way that carrier lives? Meaning, what is their work life? How much do they travel? What do they do in terms of how do they eat? And, what is their lifestyle like? Also, you're going to set up some boundaries and you're going to talk about what the expectations are for communication, right? You want to make sure you're on the same page. If you feel like you're going to want to talk to that carrier every single day and they don't want to do that, that's not a good match. So you have to make sure you're on the same page. And then finally, alignment on ethical considerations like reduction, termination. Vaccines were a big one with COVID. Just making sure the things that potentially can come up during pregnancy are discussed. And then finally, in the US, our carriers do get paid. In Canada, they do not get paid. But this is usually managed through the agency unless it's a relative or a known surrogate that may be managed separately. Next slide, please. So gestational carriers, unless they are known, have to meet some basic criteria. They all have to have had at least one full-term healthy delivery, right? They also have a bunch of other obstetrical things that we won't go through, but the agencies know certain criteria before they send us carriers for review. So there's some expectations out there of what we're looking for in a carrier. And we're not being picky. We're here to protect you as intended parents and your unborn child. So we're looking for a carrier that is the lowest risk to carry your baby safely. So once we get this carrier, we're going to review her medical records and very specifically her pregnancy history and birth records. She will also, with the agency, have a criminal background check and financial background checks. She will have a psychological evaluation, which is very long, and also a screening of their primary support person, which is also part of their initial workup. They'll have a personality assessment done by a clinical psychiatrist or psychologist. They'll have infectious disease screening, ultrasound, and finally some sort of evaluation of their uterine cavity. So there's a lot of steps that they have to get through. And again, probably about 5 to 10% of people who apply to be a carrier will actually get through. So it is a very stringent process even to get to the review of record piece. Next slide. So once we've approved the carrier, there's usually a couple-week window there where the final legal contracts are completed. And once those final legal contracts are signed, we can initiate medications on the carrier. So most of the times the carriers are out of state or not in the same state as the clinic or the intended parent, and that is really common. So we do coordinate with the agencies to find a clinic near them to do what we call outside monitoring. We can't keep a carrier with us for 4 weeks when they probably have family at home and work and job and life. So we set up a clinic for blood and ultrasound that can monitor them, and they send everything to us at every visit for us to review. When we review everything, we then contact the intended parent and the carrier and the agency so that everybody involved knows what's going on. But the goal during an embryo transfer cycle, most of the time, is to suppress ovulation. So we don't want the carrier to ovulate her own egg during the process. There are some exceptions to this, but that's a typical cycle. And then the most important thing is to prepare the uterus for transfer. So what we're trying to do is mimic what happens in a natural cycle. So make the uterine lining nice and thick and look like and act like it does in a natural cycle when it's ready to implant an embryo. So once the embryo, the lining looks beautiful and the hormones are appropriate, we plan out that transfer. And the transfer is done while the carrier is awake. They don't feel anything. They have ultrasound on their belly, just a full bladder to let us see. The catheter is very thin, takes a couple seconds, and the embryo is dropped in the uterus here. They will continue some hormonal support, which often includes some intramuscular injections till 10 weeks, and that's until the placenta takes over. But these transfer cycles can vary based on clinic and also based on your carrier's medical history and other considerations. All right, so all of this hopefully comes down to this day where you get this positive pregnancy test. And most of the time we do this blood work on average about 10 days later. And they'll get a beta HCG level. A lot of times people are taking these tests at home, so they'll also show us those. And then we will, as a clinic, monitor the carrier for the initial part of the pregnancy. And each clinic varies, but at least for a couple of visits. We're looking for an early ultrasound with the yolk sac and then an embryo and heartbeat at least. We're going to continue our medications until the placenta takes over. And then she will continue the rest of her OB care, generally near her house, typically with the OB that she had her other children with. And again, that'll all be coordinated by the agency and her care will proceed through there. Next slide. So finally, it's a long journey. So what I always say is that, yes, everybody's journey is unique, but it's a journey. And most of the time, there are different pieces or parts of the journey that get hard. And there may be pieces that don't go smoothly because we're dealing with humans and their biology and not every egg is perfect and not every carrier works out and not every embryo results in a pregnancy immediately. So embrace the journey. Remember why you're doing this. Try to stay positive. I think as long as you have people around you, like a clinic, agency that you trust, lean into them, lean into your support system, use your resources, and just kind of remember what the end goal is, and you'll get there. It just sometimes takes some turns, unfortunately, but this is what we're looking for in the end.
Wonderful. Thank you very much, Dr. Bloom. There's a lot of insightful information that you covered during this presentation today. I learned a lot today, so thank you. Our first question actually asking if you can, briefly elaborate on how the process looked like for lesbian couples.
Say that again?
Lesbian couples, if you can elaborate a little bit on how the process would look like for them.
Can I ask a follow-up? With using donor egg or with just donor sperm?
I will ask a patient who dropped this question to please specify. So we will maybe move to a next question while I'm waiting for that clarification.
And I can answer both, but.
Wonderful. The next question is, if we are using gestational carrier, how do you synchronize day cycle with the egg donor's retrieval and embryo transfer?
So typically they're separated because most of the time people don't have a gestational carrier when they're creating embryos. So if you're working with an agency, the agency wants embryos created before they will match. So those embryos are frozen, and usually there's unfortunately, about a year or maybe 6 to 8 months between the time that those embryos are created and then we're transferring. So we don't need to sync those cycles. Um, Also, most people are using carriers are going to do genetic testing. So anytime we do genetic testing, we are always freezing embryos and there's no synchronizing of cycles. The only time we synchronize a cycle is in a setting where we may be using donor eggs, um, and we're transferring it into the attended parent. So say a couple is using a donor egg, but one couple has a uterus, one partner has a uterus, and they're not going to do genetic testing. We would, the retrieval would happen, fertilization would happen, and we would prepare the carrier, and then we would synchronize the transfer based on the date of retrieval. Very close. It's an exact thing. We plan it out and it's exactly 5 days after the retrieval. But that's really the only situation we see that happen in, is when we're using typically donor egg and one of the intended parents are carrying. They don't choose to do genetic testing, and we're not using an outside gestational carrier.
Okay, perfect. Yes, and we actually received two similar questions. So both we received clarification on the first question, and a similar question came out. Interested in hearing about donor sperm for lesbian couples.
Sure. So we can do this whole another lecture in itself, and I have many of them. But but really, if we're thinking about donor sperm, really you have the same options. You're looking at anonymous or open ID or a known donor, and or a matched service. Typically, I have the same conversations with our female couples about family planning goals, looking into see how many children they want, who wants to do what, meaning does both parents want to use their eggs, or does one partner want to carry the pregnancies and the other partner doesn't. And I think based on age, based on the number of children they want and what their desires are about who is involved in what piece, we come up with some plan for treatment. And the options are typically either inseminations, where we put the sperm into the uterus the day of ovulation, with or without medications, or a lot of times people are now moving to IVF because we're seeing a lot more reciprocal IVF. We see a lot of IVF used for family planning because they want multiple children with the same sperm donor, and sperm is very expensive. And it's hard to know if you're going to have enough sperm left over to have multiple children with IUIs. So a lot of times we can get one or two vials and create all our embryos for multiple children with one IVF cycle.
Okay, perfect. Wonderful. Thank you very much. The next question, I hope I understood this question correctly, but if I misinterpreted this question, please correct me and drop this clarification in the chat box. But if we are using my partner's egg and donor sperm, and I will be the one carrying the pregnancy, what does this process look like medically? And are there any additional steps or consideration involved this type of reciprocal IVF?
Yeah, so a couple different ways to do that. So that's basically what I was explaining. So if one partner is doing the egg retrieval, that partner would go through exactly that IVF cycle that I explained, except we would fertilize the eggs with donor sperm. If you wanted to transfer an embryo without genetic testing, we can coordinate the other partner's cycle, just like I explained with the donor egg. So that way, 5 days after the one partner's retrieval, they would have an embryo transfer. Okay. So that's one way. If they're going to do genetic testing or we're looking to preserve embryos for the future, then those embryos can be frozen. And then anytime later on, we just prep the other partner for transfer cycle.
Thank you. Can I carry my egg and partner egg at the same time using the same sperm donor?
Um, Technically, yes. Um, Not recommended, and a lot of clinics will not allow it. So, sort of another conversation that comes up a lot with our same-sex male couples as well is um, the goal with IVF is for a single embryo transfer. And the reason behind that is because multiple gestation pregnancies are high-risk pregnancies. We see a lot more premature children and really all the manifestations of that. Also much higher risk for the carrying person as well. So really all our guidelines want us and tell us to transfer one embryo at a time. There are exceptions to that. You know, sometimes when people have had full-term deliveries, multiple full-term deliveries in the past, and they want to put two, that's where I feel a little bit better because they've proven that they can have healthy full-term deliveries. But to have someone who's never been pregnant before and put two embryos back, it sets people up for potentially a bad outcome.
There is a follow-up question from that just came out. So no twins? Question mark.
Yeah. So some clinics will do it, some clinics won't. The recommendation from the American Society of Reproductive Medicine is no. Again, it is a clinic to clinic decision. For gestational carriers, I think there's a little bit more flexibility because all of these carriers have had full-term, uncomplicated deliveries. And to me, that's one of the biggest predictions of being able to carry a pregnancy to term and having less complications is proving that you've done it before. So in some situations, I feel like those are the ones that happen more. Also, we're seeing a lot more insurance coverage for IVF, and a lot of insurance coverage will not cover your transfer cycle if we transfer more than one embryo because it is against most of the medical guidelines.
And please correct me if I'm wrong, Dr. Bloom, even if you're transferring one embryo, you still have a chance potentially have twins and you.
About 1%, a little less than 1%.
Perfect, thank you. So our next question, if we're using donor sperm and my partner's eggs, and I will be the one carrying the pregnancy, there are any steps that we need to be considered or aware of as an intended carrier?
So I think that's pretty much the same question. I think, you know, other elaborations of that, the person who's using their eggs, they would need genetic carrier screening, like we talked about with the sperm and the egg donor, to make sure that you don't match the donor sperm. And then the person who's carrying the pregnancy would need some evaluation of their uterus. So, you know, ultrasound, usually sonohystogram, hysteroscopy, something like that is typically recommended before an embryo transfer. If there's any comorbidities or medications that are not safe in pregnancy, those would need to be optimized, changed, you know, clearances, things like that, optimized weight. So really whole preparation for pregnancy, make sure vaccines are up to date, that kind of stuff would be more for the person who is going to carry the pregnancy.
The next question is about, you touched base on PGT already during the presentation, but I think there is a clarification that's required. Do you recommend PGT testing for all embryos created through egg donation, even if the donor is young and healthy? Or what would be your
Yeah.
advice?
So I think that this kind of goes back to who these embryos are going into. So I would say that the majority of intended parents that are using gestational carriers will do PGT. I very rarely have a couple that decides not to, because again, you're spending a lot of time, money working up this carrier, and you want to get to pregnancy quicker and you want to reduce that risk of miscarriage. And even in a young patient, you're still going to have about a 20 to 30% aneuploid rate, which means that not meaning that they're going to necessarily they're not going to have a baby with Down syndrome is very low, but they're going to potentially have a pregnancy that doesn't, transfer doesn't result in pregnancy or an early miscarriage. So for gestational carriers, I think it is probably very useful, and I think most people do that. I think where it changes is if you're transferring an embryo into yourself or your partner. So, I have several same-sex female couples who are older who need donor egg. So they're using donor egg and donor sperm, and one partner is carrying. And those people, I don't really recommend it or don't say like, yeah, I don't think you have to do it. And most of the time, those are coordinated cycles. So again, we thaw the eggs usually, fertilize them with sperm, and we coordinate the carrier's cycle to transfer the embryo when the embryos are a day 5 blast. And we transfer one embryo at a time. Sometimes people decide if there's extra embryos to genetically test them, or they just freeze them. But those are the two scenarios. So again, you're still going to see an aneuploid rate about 20 to 30%. So it sort of depends on, to me, if it's a carrier or it's yourself. I think there's a big difference in counseling and decision making.
Well, thank you. Our next question is, are there any risk to egg quality if one partner has been on testosterone or estrogen therapy?
So testosterone, no. So basically, when we have trans patients that are on T, we typically can just take them off testosterone. And usually we'll get a bleed within 1 to 3 months, or we can trend testosterone levels down and start an egg retrieval very quickly. All the data says that there's really no difference in quality. Now, any people can have quality issues regardless of their what they were taking prior. So it doesn't mean that coming off testosterone means that that person can't have an egg quality issue. I've seen that as well. But as a general rule, in patients coming off testosterone, there has not been shown to be a difference in egg quality. I'm not sure about what we're asking about the estrogen therapy. Estrogen typically tends to be in our trans women. And that, we hope or we encourage our trans women to freeze sperm before they start estrogen therapy, because it's fairly easy, unlike an egg retrieval. And we see more and more people before transition freezing. I see patients all the time, young patients all the time, to freeze sperm for this reason. But now more and more, we're also learning that coming off estrogen, most people will actually regain some sperm function and their abilities to either produce or extract sperm in some period of time. The problem is the amount of time to regain that function can vary and can be very long, and the gender dysphoria associated with that can be severe. So it's easier if we can freeze before, and what's recommended, where our trans men, we can take them off for a very short period of time, do an egg retrieval, and get right back on. So it tends to be a lot easier process for waiting to freeze eggs till we're ready or know that we want to do it, than having to freeze eggs on young, trans boys when they don't know or not ready. It's a big project.
Thank you, Dr. Bloom. I have 2 more questions that I see pending. So if one partner is going to be the sole carrier of the eggs, how long it is recommended before I could get pregnant again?
Just making sure I'm following all the loops. So typically a year between pregnancies. So what's recommended is from birth to the next transfer. We usually say a year. So when my patients graduate means we graduate them onto their OB usually around 10 weeks. We always talk about what's next, how many embryos we have, what are we doing next. And I always tell people to kind of come back, touch base around that 10-month mark, and we can update labs, do ultrasound, and prepare for transfer and transfer an embryo around that year mark. Also, most of the time, if we're nursing, there's some of our hormones that we have to be mindful of. So that sometimes limits that next transfer. it depending on how exclusive we're nursing and where we are with that weaning process.
Excellent. And we just have time for this last question. What is the cost? Well, you most probably will be talking about from mainline fertility clinic standpoint. What is the cost to have my partner egg fertilized and transplanted for me to carry?
This is a reciprocal IVF
Mm-hmm,
we're
it
talking
seems.
about. I don't know the exact number.
It,
So there's so
varies.
many components that go into this, right? Because it all depends on what sort of insurance coverage we have as well, right? So if there's two partners and they have different insurance coverage, and even if one has some coverage for fertility, you can use that for your piece of it. So even if one person has coverage for the retrieval, we can use that even if we're not using it for the embryo transfer. So these are going to be billed separately. So it depends on what's covered where. And then it depends on the someone's egg reserve, how many eggs they have, their age in terms of the protocol and how much medications we need. That can make a big difference in the cost of medications. There can be a big cost difference if we're going to do genetic testing or not. So there are a lot of factors that go into this. I would average probably, and I'm going to be making this up, 20, 30,000-ish, give or take, depending on the range of where we are, but split up, and often people have some coverage for a lot of those things as well.
Thank you very much, Dr. Blue. Wealth of knowledge you shared with us today, a lot of
Yeah.
important information. And for patients who starting the journey have questions, please do not hesitate to make appointment with Dr. Bloom. By scanning this QR code, you'll be able to get the link. She is in Mainline Fertility once again in Philadelphia. Thank you once again, Dr. Bloom, for your time. Everybody will receive a copy of this recording as well at a later time, and please do not hesitate to join us next month. There's a lot of interesting topics that we'll be covering. Thank you, and have a great evening.
Thank you, Irina, and everyone, good luck. Thank you.
Bye.